Welcome, everyone. Thank you so much for being here to the next episode of our meeting of our webinar reading series. And as usual, what we'll do is I'll introduce you to Casey McKenna, the Senior Program Manager for the NFDF for Education and Community Support. Casey is going to introduce you to Dr. Jefferies, who most of you probably already know. And Dr. Jefferies is going to give us a new presentation tonight on a different aspect of Fabry disease education. So thank you so much for Dr. Jefferies. Thank you, Casey. Thank you, everyone, for being here. And Casey, take it away.
Great. Thanks, Jerry. And thank you all for being here. As Jerry said, we're going to proceed with the presentation. If you have any questions along the way, feel free to put them in the chat. I'll interrupt you, Dr. Jeffries, if anything big comes up that we need to make sure we're all on the same page, but otherwise I'll hold the questions for at the end. And then without further ado, let me introduce Dr. John Jefferies, who many of you who have been to our conferences or seen some webinars have probably seen his face. He is a large member of our YouTube index. Dr. John Jefferies is an internationally recognized cardiologist specializing in cardiomyopathies, heart failure, genetics, heritable disease, artificial intelligence, and rare diseases. Fun fact, Dr. Jefferies, while he has many different acronyms after his name, my favorite fact is he is the team cardiologist for the Memphis Grizzlies. And he is here to talk to us today about cardiac imaging or advanced cardiac imaging and Fabry disease. So with
Y'all,
that, welcome, Dr. Jefferies.
thank you, and good to see everyone. And hopefully you can see my slides okay.
Yes.
So I was asked to review an article, and so we'll go through a little bit about the article itself. And thanks again for the opportunity. I always enjoy these discussions. As y'all know, I'm involved in a lot of Fabry with Sanofi, Chiesi, you name it, pretty much every company, and I still hold some NIH funding as well. I don't want to belabor the stuff too much here about the background of Fabry. You guys know far better than I about the disease, X-linked, obviously, deficiency, and alpha-galactosidase A. And the question is always about how are we progressing in our management of this disease and are we making progress? So Jerry had made me aware of this article, which I'd seen, but I hadn't spent as much time on. And so I took, a fair amount of time to read through it. And this is going to be the topic of our discussion this evening. And our goal will be to, try and get through the lecture in about 30, 35 minutes or so, and then spend time asking questions and providing data. And hopefully you'll see some impact about in this in your own lives for your families. A lot of these things you've heard from me and maybe some of our other speakers around cardiology. But what this article is, so it's a contemporary article, it's published this year in the International Journal of Cardiology, and you see the title, Impact of Cardiac Magnetic Resonance on the Clinical Management of Patients with Fabry Disease, Data from the CMR Italian Research and Clinical Network for Fabry Disease, or CIRCLE FD. So a couple of things from this. One is we talk about cardiac magnetic resonance. We're talking about cardiac MRI. And really, this is kind of a cool registry now. We always wonder about how translatable things are if they're done in Europe, for example, to how we can use those in the United States. But this one is actually eminently translatable. And a lot of things we'll talk about from this particular study you've heard from me in prior lectures, but this reinforces the idea that it actually can be what I would say operationalized. So some things we talk about are sort of esoteric and only can be done at academic centers, but this is a little bit different. So this is the abstract for the paper. So importantly, once again, this is from Italian centers, and we'll talk a little more about those centers in a couple of slides. But basically what they did is that they sent out a survey, so just a questionnaire to people that were actually a part of this network. And so you see that a survey was assessing the impact of CMR, so cardiac MRI, on the clinical management of Fabry disease patients was sent to the referring clinicians. So these are people that are sending patients for MRI at this network, this Circle FD. And so the real subject was does the MRI make a difference in management in some way? And we'll talk about what those impacts on management were in a few slides. But it was a cool idea because the imaging matters, but what really matters is how does it inform the management of these providers that are sending these patients for these studies. And you can see here that they found that the data were useful, and we'll drill down into this in a few minutes. 17 clinicians responded to the survey, and what they thought was that the cardiac MRI was thought to be useful when you look at the conclusions in the abstract. So this is kind of an abstract's kind of the amalgamation of the paper into 4 bullet points: objectives, results, or 3 bullet points in this particular one, and conclusions. And really, what they thought was, what were the different sort of subtypes or parts of the imaging that made a difference? And we're going to drill down into those. But it not only made a difference in clinical management, but it also opened up ideas for research opportunities, which is obviously important. I just wanted to contextualize this a little bit. I thought it might be useful just to remind everyone. And once again, we've talked about this over a series of lectures, but we know that the clinical implications of Fabry are robust. And what we want to spend time is mostly thinking about this top sort of quadrant is what are the imaging findings that we encounter in Fabry disease. And so we know there can be thickening of the heart, the concentric LVH or left ventricular hypertrophy. The GLS stands for global longitudinal strain. So that's a marker of sort of focal myocardial function. We know that the big artery, the aorta, can be dilated in patients with Fabry. But then there are other changes. You can get changes in the valves, specifically the aortic and the mitral valve. And then when you get really sort of profound or advanced phenotypic disease, we start seeing things like scar burden. And so it's important to understand that these are the things that we're looking for, and how is it that we typically kind of do surveillance for this stuff. So this is kind of the timeline, and this is important because this kind of informs how we're going to do our imaging studies. So we know that over time, as we do storage, you can get dysfunction of the heart muscle, so squeeze and relaxation abnormalities. This leads to thickening over time, and then you get kind of end-stage myopathy when you start seeing death of the cells themselves. But you can see some of these other things when we look at the imaging piece. Some of the earliest ECG findings or EKG findings we see are bradycardia. So those are some data we published a long time ago in our pediatric patients. But then the question is, well, what's kind of the next step? So we see these electrocardiographic. Well, the next things we see are impairment in that global longitudinal strain, which interestingly you can see both on echo and you can see on MRI. So we'll talk about the benefits and limitations of both of those studies, but also this low T1 signal. And we can only get T1 information from cardiac MRI. So if you think about it, if I'm trying to find the earliest marker of cardiac involvement, how am I going to do it? Well, these are typically the 2 options, the impaired strain or the T1. The advantage of MRI is I can actually get both of those. As things progress over time, I might see evidence of T2. So T2 is a marker of sort of edema, so fluid. So when I see T2, that tells me there's probably inflammation in the heart muscle. T2, once again, is something I can only get from an MRI. T1 I can only get from MRI. And this LGE, or late gadolinium enhancement, I can only get from MRI. So you can see here there's some inherent advantages to doing MRI from someone who manages a fair amount of Fabry. The question is do other providers see the value? And that's kind of what the purpose of this paper really is. So we know the cardiovascular findings, obviously arrhythmias, heart failure, myocardial ischemia, or when the heart doesn't get enough oxygen, and stroke. And all of these things have upstream sort of precursors, and most of them are based on the imaging data. So I thought we'd take a little bit of time just talking about echo versus MRI and what are the sort of advantages and disadvantages of each. So I'm sure all of you have encountered echocardiography, so that's just a fancy word for ultrasound of the heart. The advantage of echo is that pretty much every place has it. It's relatively inexpensive. highly accessible, and we even have portable modalities for echo where we can go to the bedside with a little handheld thing about the side. You can even like play it through your phone, your iPhone, with a probe, and you can do it. So that means it's very portable. I can do it over and over and over. I can almost do it continuously if I really needed to. So that's an advantage. I don't need to get into a scanner. It doesn't require a lot of pre-work. It doesn't require an IV, any of those sorts of things. And these are kind of the pictures we see. These are still frames. Usually they would be moving. But when I talk about echocardiography, I usually equate it to like black and white TV. We do have some other opportunities, but when we look at echo, you can see it's kind of grainy. It's black and white. As I said, this would typically be moving, but the images aren't particularly sharp. And everything kind of either looks black or white. So there's really no definition of what's going on in the heart muscle itself. Everything that appears black here on this particular screen is blood inside of the heart. And so this would be looking at the long axis of the heart, and this is the way it looks in short axis. So if I cut it like a donut, and these just represent images. On the left would be a normal heart, and so this would be the normal thickness of a heart. And then on the right would be a patient with Fabry where it's thick. So this is that left ventricular hypertrophy. And then, as I said, we can do the strain imaging that we talked about with echo as well. And that's kind of our color coding specific areas of the heart muscle. So I look at specific regions of the left ventricle for the purposes of what we are talking about. And that can be an early biomarker of cardiac involvement, even if the heart squeeze is still normal. So the ejection fraction could be completely normal, but the strain imaging can actually be abnormal as kind of one of the first findings of someone having cardiac involvement or a cardiac phenotype in Fabry. Once again, you can do strain imaging both on the heart with echo, but you can also do it with MRI. So the advantages of MRI, we've kind of made a few arguments already. It's very reproducible. So compared to echo, if I put someone in a scanner over and over and over, I'm going to pretty much consistently get the same results every time. Because I have the ability to look in 3 dimensions, I can calculate the volumes of all the chambers of the heart very thickly. So there are 4 chambers. And I can also very well characterize the thickness of all of those chambers, which actually matters. Importantly, I can see everything else in the chest. So I can see the lungs, I can see the vasculature, I can see the esophagus, I can see some of the bony structures. So all those things are added information that I get at the MRI in addition to getting good pictures of the heart. And most importantly, I can characterize the heart muscle itself. So this is the ability for me. So this would be an MRI without contrast. And you see kind of this is the left ventricle, this picture that we're looking at here. And then over here is after I give contrast or gadolinium, you see this where it was black. Inside of this black are these white areas, kind of this white cloudy looking stuff. That is LGE or late gadolinium enhancement. And that represents scar. And that matters for us for a variety of reasons that are beyond the scope of this particular talk. But that's some of the information that I can get from an MRI. And then importantly, we can do this T1 business. So T1 is kind of cool because with native T1 imaging, I don't have to give a contrast agent. And that matters because people with renal dysfunction, which we know is relatively common in Fabry, can't get exposed to the contrast agent that we use, which is gadolinium. So if I can't give gadolinium, but I want to know if there's been damage to the heart, how can I do it? This is the T1 and specifically native T1. So that means prior to giving contrast agent. And here's just some pictures kind of depicting that, where you see the heart. This is a normal heart on the left with all the pretty green area. And then the one in the middle is actually a Fabry heart where though it should be all green, you see these different colors, red, blue. Those represent areas of abnormal T1 imaging. And that sort of over here at around 4 o'clock, this kind of yellow, orange, kind of reddish area actually represents scar burden. And this was verified in this patient because they gave contrast and you see it lining up in exactly the same spot. So that's the advantage of the T1 is that I can avoid some of the contrast agent. And also, interestingly, is kind of a more of a physiology or anatomy kind of a piece. But I can actually also look at the heart more specifically, independent of what's going on with the muscles. So we all kind of think about the heart as just being a big totality of muscle cells. And in actuality, all those muscle cells reside on a framework, kind of like if you built a house and you put up the studs in the framework in the house. The studs in the framework are what are called fibrous tissue. And particularly, we call it an extracellular matrix. And on top of that matrix is where all of the cells live. So they kind of get plastered on, like sheetrock, for example. And that we can actually calculate the volume of that extracellular matrix using MRI. It's called ECV. And we can get that information from using MRI, and I can't get that from using echocardiography. So what you see here is a B represents the heart in a section with all the muscle and kind of the lattice work, which is the white. Then we enzymatically digest all the muscle off, and here you see this lattice work. I can actually calculate the volume of that lattice work using MRI, which is kind of interesting. So just to kind of recap, so this kind of helps you frame the importance of this article, I think. Echocardiography advantages is widely available, as we talked about. There are really no contraindications to echo, interestingly enough. We don't typically have to give a contrast agent. Occasionally we will if we don't have great windows. Sometimes we will give an IV contrast, but usually we don't. I can look and see what's going on with the squeeze and calculate things like cardiac output in a very rough way. I can see what's going on with the valves. It's relatively quick for the most part. And I don't have to put anybody in a scanner. So it's like sort of a claustrophobic kind of an environment. But there are disadvantages. It's very operator dependent between echosonographers, between clinicians. The images can be very different and the acquisitions can be different. Some people have unusual chests, maybe a thick chest. Sometimes you have scoliosis or kyphosis. If you have lung disease, sometimes those can make it hard for you able to see the heart because it's an ultrasound. We can't really see the right side of the heart very well. And we can't characterize the heart muscle, which is what I was telling you is really what matters to me as a Fabry provider. And there's a lot of bias. If I were to show the same echo to 3 different providers, I would likely get some minor deviations in the numbers, like the ejection fraction, for example. Cardiac MRI advantages. Gold standard for looking at the heart muscle, the volumes, the thickness, all that kind of stuff. Doesn't matter what the body habitus is, as long as you can fit in the scanner and you can meet the weight requirements of the scanner, which is usually around 350 pounds. We can look at the heart, as I said. I can look at the right-sided structures, and I can very accurately measure the thickness of the heart in all of the chambers in any part of those chambers. But it's more expensive. Not everybody has access to MRI. Certain devices like pacemakers, defibrillators, stimulators, sometimes are a contraindication to getting an MRI. Newer generations, we've kind of avoided that, but for older generation devices, that can be a problem. We can't give the contrast, like I said, in people who have advanced kidney disease. Sometimes if you have arrhythmias like atrial fibrillation or a lot of PVCs, that can make the image quality a little bit compromised. And then if you're claustrophobic, MRI is hard because it's a pretty small little tube that you're put into. Some additional advantages, as we talked a little bit about. No radiation. Sometimes there's this misconception that MRI has associated radiation. There is no radiation. Now, CT, different discussion. MRI, no radiation. But like I said, the cool thing is I can look at all the other stuff in the chest. And remembering one of the implications of Fabry disease is enlargement of that aorta or the artery that comes off of the heart. I get all that essentially for free because I'm already there looking at the heart. I get this additional information. I can also look at the lung structures. I can look at the rest of the vasculature. I can look at lymphatics. All this kind of stuff is kind of interesting and important for Fabry. So how does that inform the study? So now that you're armed with all of that information, this was the subject. I found this online. This is kind of a synopsis or a snapshot of the article itself. So you can see here, this is Italy. And put it in this normal part, you see where the heart is, that was the coordinating center. And then you see the little white dots are the participating centers. So there are a few in middle and southern Italy, but the majority of them are in northern Italy. And these are data that were collected over an 8-year period, which is pretty good. There were 217 patients that were referred, and the basis of those was 360 MRI scans. So obviously a few patients got more than one scan. The network itself are these group of physicians that are reading that, and they're very experienced, which is an important thing to remember. So they're experienced in looking at MRI and experienced in looking at Fabry-based MRI. They used very standardized protocols, which is great. They ultimately, this is kind of cool. They actually would call up the referring provider and tell them about the results, which doesn't always happen in the United States. That would be nice. And then they were able to collect some scientific data for publication, such as this. And so remember, the subject of the study was sending out a survey to the referring doctors, specifically asking, did this help? When we sent you for a cardiac MRI and you got this information back, did it make a difference? And the answer was yes, in 72% of cases, which is pretty remarkable. And we'll talk a little bit more about what that was. We'll drill down, but the three kind of areas that they focused on is that they felt it made a difference in the idea of initiation of therapy. So, my job is, if you come to see me, is that one, if you have Fabry diseases, do you have involvement of your heart muscle? Traditionally, we would have used echo. Well, now you've seen all the reasons why echo may miss the boat, right? I can't do the T1 imaging, I can't do the T2 imaging, all this other kind of stuff. And so now I have a tool that I can diagnose cardiac involvement earlier upstream. And remember, if you have cardiac involvement, you may be a candidate for therapy, like ERT or chaperone therapy. Next is, how is it implicating management? So am I using MRI to adjust my therapies? And then lastly, does it give me information on how frequently I need to follow up with a patient, which it does. So, and you can see down at the bottom, what were the main things that they thought were impactful from what they learned? The overwhelming majority is that T1 Marcos, remembering that's the earliest biomarker we're going to see, the earliest finding on MRI of involvement of the heart in the setting of Fabry disease. So this is kind of reframing what we just talked about. And you can see here graphically, they really felt that the management of the Fabry disease specific therapies. So once again, we were talking about ERT chaperone therapy, for example, over half of the time that MRI was actually important in making those decisions. When we talk about cardiac therapies, those may be more implicated around like devices, so like pacemakers, defibrillators, but it also could be other non-Fabry specific cardiac management medications like ACE inhibitors or ARBs or ARNIs, or the things that you've heard me talk about in the past. And then lastly is just about the timing of follow-up. So meaning, if you had a clear MRI, I might put off follow-up a little bit longer. If I thought your MRI was progressing, I might see you sooner. So those are important for things that help you to understand how to monitor patients over time. And then what were the findings that influence specific kinds of therapies? I love this first part about starting therapy. So once again, the biggest question for me as a new Fabry diagnosis is, how is my heart? And MRI gives me that information in a lot of different ways. But you can see here, once again, that T1 imaging is driving a lot of the boat about, hey, I'm on the fence on whether or not I'm going to start therapy. That presence of T1 tells me you have a cardiac phenotype and that you would qualify for therapy, whatever their therapy that is. Obviously, this topic for a different discussion. Next would be the thickness of the heart, so the left ventricular hypertrophy, equally this late gadolinium enhancement, so the scar tissue that we see when we give a contrast agent, okay? So all of those are informing, hey, do I need to start therapy or can I avoid starting therapy? So obviously, if you didn't have any of these, we would say, well, you don't have a cardiac phenotype, we don't recommend starting therapy specifically for cardiac involvement. Next is no start therapy. Once again, that T1 being normal helps a ton. We've talked about this before, but Fabry is unique. Most cardiac diseases like traditional heart failure that I might see, or an amyloid patient or someone with hypertrophic cardiomyopathy, their T1s actually usually go up. Fabry is one of the very few diseases where the T1 actually goes down. So if it were normal, I would say, well, we're good. If I saw that number starting to drop, I'd say, well, you have cardiac involvement. And then lastly, obviously, this idea of heart muscle thickness, which is very reassuring if you have normal myocardial thickness and normal T1s. And then are you going to change your therapy? And you can see these are relatively equivalent. There was a little bit more driver in the presence of the hypertrophy, But all those three factors really inform providers about, hey, am I good on where I am, or do I need to modulate therapy? Meaning, do I need to add something else? Do I need to adjust the dose? Do I need to adjust the frequency? All that sort of business. And this is kind of the central figure of the paper, and it's quite good. And you can find the paper online, and I'm sure the team would make it available to you if you'd like to read it. But this kind of sums up what these investigators were doing with every MRI. So part of it is just looking at, like we said, at all of the function and the size and the shape of the ventricles. That's what these cine films. So you can see here kind of these cross-sectional and long axis views to give us the ability to really calculate how big the chambers are. The T2, remembering once again, the T2 gives us an idea of edema. So all we're saying is there fluid in the heart that shouldn't be there. And we usually leverage that as a kind of surrogate marker of inflammation. So for example, I would easily use this in someone I thought that had a COVID infection of the heart or like myocarditis. I would use exactly the same kind of imaging. It represents inflammation. T1 we talked about, we're looking for scar burden, and the advantage of T1 over the late gadolinium enhancement is that I can look at multiple areas in the heart muscle, whereas LGE is usually relatively focal, and then we can do mapping post. So you can imagine all of these things are good, telling you about where you are, but it also, you can use it over time to see if you're responding appropriately to therapy. The authors concluded, and I would agree, is that they felt like this really did impact clinical management of Fabry in a good way. Native T1 data was felt to be particularly useful, which I would agree with. And but there's some caveats here is that, as you see, to optimize its efficacy, CMR and Fabry should be performed by expert imaging specialists in close contact with referring physicians. So that's an important piece of data. So it just means that you need someone who's aware of MR, and specifically what should they be looking for on MRI in the setting of Fabry disease. Some of the takeaway learnings. These are some of the limitations. If I were reading this critically as a cardiologist, say it's a survey-based study. So were people being honest? Did they take time to fill out the surveys in a thoughtful way? Still a pretty small number of reviews and patients, but in the Fabry world, it's a reasonably sized cohort. There weren't that many providers responding, but that's okay. Even in the US, we don't have lots of providers that specifically manage Fabry. Interestingly, the majority of patients were female, which we wouldn't usually see in a clinical study in Fabry, in my experience at least. So recognizing that sometimes the phenotypic impact on female patients could be a little more variable, but that's an important thing. Obviously requires cardiac MRI, which we talked a bit about. And then these were interpreted by experts. So if you have access to experts, that's great, but sometimes you don't. But what are the good things to take away? Cardiac MRI adds a lot of value to Fabry management, which we've known for a long time. I think the study just reaffirms the idea that referring providers think that it really does help them in the management of patients. It tells us about the T1, the structural piece we talked about, and how much scar there is. It does give us the idea of, for patients when we're going to institute therapy, which is a big deal. As you all know, once we start that therapy, we're probably going to be on that indefinitely, and it's a huge investment of time, especially on the ERT side. It does give you benefits in optimizing or tweaking your medical management independent of a Fabry specific therapy, and it gives us some potential research targets. So I will stop sharing there. But I thought all in all, really good paper, really informative. I think it reaffirms a lot of what we all believe. And I hope that gave you guys a little bit of groundwork to reframe in your own mind why we like MRI so much in Fabry. To me, that's the gold standard for what I'm doing on the heart side. And I think the study just kind of sort of reinforces the idea that we get data that makes a difference in outcomes in Fabry. So thank you.
Dr. Jefferies, thank you so much. That was a, really interesting presentation. And you deliver it so well, always. but we
Oh,
really appreciate you. How about questions? Do we have questions?
We don't have any questions in the chat quite yet, but if you want to type them in or if you want to jump in and ask them, feel free to do so.
yeah. Maybe it just means that was a good explanation. Fingers crossed.
Yeah.
It
But
was. No, it really was.
Yeah.
but but yeah, I mean, we can talk. We don't have to talk about the article specifically, as you guys know. You guys usually have access to me for other things. But are there things that does this does this set off a light bulb in your head, or is it just like, yeah, I knew that, and this absolutely kind of reinforces what I already knew?
All
So
right. I think we have a question from Emily over here.
Hi, Dr. Jefferies. Thank you so much. Absolutely agree. I have a great cardiologist at Dartmouth, who is making sure that things are done well on this end. Um, I wanted to pick your brain just for a second, and it's interesting that you bring up that this seems to be a study that has a lot of women in it, where
yeah,
that is not a normal
that's right.
part of a lot of studies. I'm currently enrolled in a course at Harvard around women in midlife. I myself am a Fabry patient. I am in the middle of midlife, and so a couple of the things that I was wondering specifically, midlife has these like just profound metabolic changes, right? Lipids worsen rapidly around like kind of final menstrual period, which increases LDL levels,
Yep.
and and even ADL becomes less, protective.
Mhm.
So as I'm thinking about preventative measures, because we are all about prevention here in the Fabry world, right?
Yeah.
Um, we also have like at the same time, the body composition kind of shifts towards like visceral fat and a kind of highly inflammatory driver, of course, of cardiovascular disease. Um, I'm wondering about things like a CAC scan. Is that something that you think as, especially as women, heart disease kills 1 in 3 right now in the country. And our risk gets, much more intense once we have hit menopause. So
Yeah.
can you talk a little bit about what you might recommend to those of us who have made it this far and
Absolutely.
are female?
Well,
Yeah.
I think a great question with a lot of nuances there. So Emily's asking important stuff. And one of the things I try and remind our Fabry patients is we already worry about you for one unique cardiovascular set of problems, but you're not immune to what everybody else is at risk for in the United States, like me, right? And it's like, hey, I got to worry about coronary disease and atrial fibrillation and all the other kind of stuff, hypertension. So that makes it, we have to be even more intentional with Fabry because we know, because you live in the US and, we're in a developed country, as you said, MI is still, the cardiovascular disease still leading cause. So we have to think about other things. So what Emily's asking about is more around risk factors for myocardial ischemia. When we talk about that, we're for this particular lecture, we're talking about the heart muscle itself. But remember, it has to get a supply of oxygen from a thing called the coronary arteries. So those live on the outside of the heart and they pump blood and they perfuse the heart muscle itself. And that's how the heart muscle gets oxygen. When you get blockages in those arteries is when you have angina or chest pain. And when you get in a complete occlusion, that's called a myocardial infarction. So anytime we disrupt blood flow distally from that artery where a blockage is, that area of heart muscle becomes vulnerable. And so that can cause a heart attack. And what we're talking about here is should we be screening for things like ischemia or coronary artery disease in Fabry? And the answer is unequivocally yes. So we know that Fabry patients are actually predisposed to earlier risk of myocardial infarction. The thing we didn't talk about here is we don't really get that kind of information from an MRI. So what Emily was talking about is a fancier kind of a scan. So we can do a relatively easy, quick CT scan that looks for calcium burden, and that's a calcium score. We do it through a thing called an EBCT, and she was talking about a CAC. That's just a coronary artery calcium score. And that's an easy, very fast test that tells you if you have calcium deposits in those coronary arteries. And that usually wherever we see calcium is evidence of hardening or thickening of that particular vessel. Calcium doesn't show up on an MRI, unfortunately. So we have to do a separate scan for that particular bit of information. We can actually extend that to an even further, so we can actually do an angiogram of those coronary arteries with the CT as well. So in the past, if we wanted to do an angio, we had to take to the catheterization lab, put a big piece of plastic in your groin, in your neck, or in your wrist, catheter, take that catheter back through the artery, the aorta, and engage the coronaries and inject contrast. And that's a coronary angiogram and very invasive, right? Based on what I just said. Now we can do it with a CT scan. So it's called a coronary CT angiogram, CCTA. And that gives us pretty good resolution in the proximal and mid portions of the arteries if there's any significant blockages. And we do that oftentimes in people as kind of a risk stratification to see if you have anything going on. There are ways to identify what your risk profile is for coronary disease. There are some calculators out there. Unfortunately, none of those calculators factor in Fabry. As most things, right? We don't ever account for this other stuff, but it's kind of a general rule of thumb. And that if you're interested after the talk, I can send you a link for you can calculate your risk score. And then we can do traditional testing too. I'm sure you guys have heard about stress tests. And cardiologists like stress tests, right? So sometimes those are on a treadmill or on a bike. Sometimes they're with a nuclear imaging. Sometimes they're with an echo. And that's another way to get at it, to look for ischemia as well. But in patients like with Fabry, if their kidney function is okay, I oftentimes think about the coronary CT angio just because I think it's really a helpful modality. And it gives me ideas of actually true occlusion, where those other things are looking for sort of induced ischemia when we talk about stuff like nuclear stress testing or echocardiographic based stress testing. But the real takeaway here is that don't forget that you have to pay attention to other things that everybody else gets, like coronary blockages, like hypertension. And obviously, there are a lot of known predispositions for coronary artery disease, diabetes, blah, blah, blah. But we know Fabry also, because of the deposition nature of the disease, can also lead to blockages as well. So, but great point, MRI doesn't. There are certain aspects of MR that we can leverage for stress kind of imaging, but we really don't use them as a first line opportunity like the other tests that I just talked about.
Thank you. There's another question from the chat. Are there any insurance coverage issues for MRI versus ultrasound?
Not typically. Now it's not without a little bit of elbow grease. So obviously, first with anything, I was just, dealing with insurance today. You got to meet your deductible. So if you're going to be getting any kind of stuff done, then you have to bake all that kind of business in. But when it comes to authorizations, insurance companies have gotten better. When I first started doing a lot of cardiac MRI, it almost always required a pre-authorization, or it would require me actually having a discussion with the insurance, with the payor, to justify the MRI. As of late, when I order MRIs, I have not met any resistance. I think they're becoming more commonplace because we use MRI in a lot of different cardiovascular conditions. And akin to talking about Fabry, we do a lot of MRI in hypertrophic cardiomyopathy, for example. So I think that the insurance companies are understanding that this is the standard of care. And so now we don't have as much pushback.
And articles like this certainly help
They
in
do.
terms of the letter of
Honestly.
medical necessity.
Yeah, because I think once you tell the insurance companies like I need this modality to understand if I'm going to start therapy or not, and I can't get it from an echo unless the echo is advanced, right?
Right.
If you had extreme left ventricular hypertrophy on echo, I don't necessarily need the MRI to verify that, but I would still do the MRI to look for scar and all the other things that we talk about because that informs a lot of other treatment strategies. So, but all in all, I think people are coming around to MRI being just an absolute need in the management of Fabry across age spectrums. When we do MRI in younger patients and older patients, and so far it's been reasonably well accepted by the payors. Like I said, I've had a few, but it's been distant where I would have to write a justification or talk to someone and say, why are you needing an MRI over an echo? And I would explain exactly what we just talked about today. And they say, okay, that makes sense. And then they would approve it. I've never had a denial in that direction.
But you've had to do
Oh
some
yeah.
appeals. Yeah.
Yeah, I had to talk to a few people. It's like, well, why do you need this fancy
Mhm.
test? It's like, well, let me tell you why. So
Yeah.
I think Jesse has a question.
Yeah.
yeah.
Go ahead, Jesse.
If you want to unmute, Jesse.
Yeah, thank you, Dr. Jefferies, for that wonderful talk. Um, so, what about the use of MRI for disease monitoring? Say we've already got someone on ERT or chaperone therapy. Is there much utility in monitoring when we're already at maximal therapy?
We do, and pretty cat, by the way. We do use it because one, as you all know, we do have opportunities to tweak therapies occasionally, or maybe do we need to modify the dosing or do we modify the timing and those sorts of things, and so we're trying to individualize therapy, which I think is a good thing. But remember, we worry about other things in Fabry as well. So, for example, to your question, I'm already on the right therapies, on the max dose. Everybody thinks, I'm where I need to be on whatever modality I'm receiving. My job is to try and keep you safe. And as Emily said, prevention is our target. We're trying to avoid bad outcomes, remembering that because of some of the scar that we might be seeing on MRI, for example, does that put you at an increased risk for things like ventricular tachycardia, ventricular fibrillation? Meaning, does that increase your risk for sudden cardiac death? And the answer is yes. And I can use MRI to monitor that volume of scar over time. And when it reaches a certain threshold, then I'm going to be thinking differently about the potential need for primary prevention in the form of a defibrillator, for example. The other thing is that we get other bits of information. We spend all of our time talking about the left ventricle in our group, obviously with most of the researchers in Fabry, but there are three other important chambers in the heart. And so things like atrial fibrillation are oftentimes driven by the size of the left atrium, so we can monitor that pretty well. And then we like to monitor the right-sided function as well. There may be other things that we want to modulate there. And it helps us to dial in additional cardiovascular therapies that are independent of Fabry disease. So remember, I should avail to you the same therapies I would give to a traditional heart failure therapy patient, for example, who had ischemic heart disease. If your ejection fraction is low, I should be thinking about the right kind of modalities. Probably the last one that we don't talk a lot about as a community is that aortic dilatation, so the enlargement of the aorta, or what we call an aortopathy. We don't typically see it get to extreme levels, and it's exceedingly rare to hear about dissection. But I can be able to monitor that with MRI, that it just gives me peace of mind that things aren't changing dramatically over time, because that's one of those I would hate to miss, because we can intervene on that one and avoid a bad outcome. Like I said, I'm cardiocentric, obviously, by nature, but we get all this other thoracic information which matters. We know lung disease happens in Fabry disease, for example. So we get this additional information by that advanced imaging. And I think you're right in that you may have plateaued out on Fabry therapy, but does it inform my other traditional cardiovascular therapies? I think it does. I think it does. But for me, a lot of what I leverage on MR at that point really is about the scar burden. I just want to make sure that you don't have a sudden arrest, and that's where I'm using it in a lot of sick. That I can use the thickness of the heart, and I can also use the scar burden. We're translating traditional kind of hypertrophic recommendations or guidelines oftentimes into Fabry, but unfortunately, a lot of times that's the best that we have.
Thank you so much. That all makes
Sure.
sense.
Yeah.
And I realize this will probably vary for the individual person, but do you have any general thoughts about how often a cardiac MRI would or could be performed in adults?
I'll tell you but I'm not, I'm I'm an outlier probably. I'm a guy that I think back, I love Emily's statement is I am all about anticipation and prevention.
Hmm.
And a lot of centers may space things out. What if you have cardiac involvement in our center, what we would typically do is every 6 months at a minimum, could be more frequent, but at a minimum, you're getting some kind of imaging. And what we would usually do is echo alternating with MRI. So let's say today is ground zero, and in 6 months, I'm going to do, so let's say I did an MRI today.
Hmm.
I'm going to do an echo in 6 months. I'm going to do an MRI in 6 months after that. After 6 months, I'm going to do an echo. I'm going to do an MRI. But obviously, if symptoms changed, hospitalization, something was different, then we would implement imaging somewhere in that. That's just our take. Everybody has their own sort of view. But, my own view about cardiovascular stuff is things can change rapidly sometimes, and waiting 2 or 3 years to me is just too long, especially if we could avoid something. And I just feel better about keeping a close eye on our Fabry patients. One, because they're just important to me as a provider, but I think the other piece is that we are still learning, right? Things like coronary disease and whatnot, we have historical data from Framingham and other studies that we have a longitudinal experience. We're still learning about Fabry. And so for me, I don't want to take the position of, well, I know exactly what's going to happen, because I don't think we know exactly what's going to happen at this point.
Any other questions or comments from the room, or you, Jerry?
To follow up on Casey's question, do your screening practices change for people who have non-classical Fabry versus those with classical?
I've tried to keep it the same. That may sound a little bit different, but um, remembering the cardiac manifestations are the same. They may be later in life. And the other thing that I've always found interesting is some of the most extreme cardiovascular phenotypes I've seen have been in females, which kind of goes against it's countercurrent to traditional thinking, right? And so for me, it's back to, I'm just trying to stay humble. Um, I don't know everything that's going to happen. And so I think every patient deserves the same kind of opportunity for surveillance. So I approach classic, non-classic, female, male very similarly.
Thank you.
Once again, this is just my approach. I'm not saying that this is, everybody may practice exactly the same, but the Fabry cohort has taught me a lot about being mindful that you just can't see what's always coming down the tracks. And I think it really is back to this prevention idea, is that I would much rather manage something that's pre-symptomatic or in early stages, as opposed to presenting to me with end-stage heart failure or an aortic dissection or refractory VT or whatever the case may be. It's just better for the patient. It's the right thing to do.
Jerry, I think I hear you talk. I think you're talking, but you're on mute.
All right. And just as you said, I've heard and read that people with later onset may have the same cardiac manifestations just later. So
That's right. Yes, sir.
thank you so much. That's a great presentation. Good questions. Anyone have
Yeah.
anything else before we say goodnight? All right. Well, thank you all for joining us, and we look forward to seeing you again. Thank you, Dr. Jefferies. Thank you, Casey, and thank all of you. Good night.